Alrighty, guys, let's do eating disorders, chapter 8. So, I always like to start off my conversation on eating disorders by returning to what should be a familiar concept, culture bound syndromes. If this is striking you as unfamiliar, refer back to some of our earlier chapters. You'll recall that we talked about formal diagnoses, which have really been the basis of our semester thus far. But we also talked about culture-bound syndromes, which would be syndromes that are not universal, but are diagnosed specifically within certain cultures. You'll also remember that the DSM is written and published by the American Psychiatric Association, meaning that it's an American perspective on diagnosis. And so, for that reason, I do find it interesting sometimes to take a look at different diagnoses that we consider to be kind of full, true clinical diagnoses, but really examine whether or not they're truly universal. And the eating disorders kind of fall into this category where, again, we consider them to be kind of full clinical diagnoses. But when you really take a look across time and across places today, we really don't see them universally in the same way that we see things like depression, our bipolar disorders, our anxiety disorders, OCD, schizophrenia. We see those things universally. But as I'll demonstrate on this slide, we really don't see eating disorders quite as universally, which begs the question, are they really more of a culture-bound syndrome? So historically, we haven't really seen eating disorders consistently. Two examples of time periods where we've seen more disordered eating are the kind of Greco-Roman and then the kind of Middle Age time periods. In Greco-Roman times, it was common to see more well-to-do Romans engage in a combination of binge eating and purging within a celebratory context. So during a party or something like that, it was pretty typical to overeat and then intentionally to vomit or purge in some other way in order to continue eating and engaging in other gluttonous behaviors. So that would be considered a disordered eating pattern, which you'll definitely see in later slides once we get into these disorders. A bit later on, closer to the Middle Ages, you would occasionally see saints engage, not saints per se, but just really devout Christians, more specifically, engaging in self-starvation within a religious context to demonstrate the degree to which they valued their souls and consequently the degree to which they didn't value their temporary physical forms, their bodies. So both of these are kind of interesting because they point to time periods, but then they also point to cultural groups within those time periods. The more well-to-do in one case and then a religious group in another case. And today we really see the same thing. We just simply don't see eating disorders universally. Instead, we tend to see them in cultures in certain places. One example that I always like to give when discussing this topic is the Fiji study. This happened in the mid-90s when television was coming to the island that previously didn't have the influence of all that television has to offer, including exposure to Western media. And so researchers took this as an opportunity to observe changes in disordered eating thoughts and behaviors pre and post introduction of television. And what they found was that both induced vomiting and the tendency to view oneself as fat increased following exposure to Western media. Similarly, today, research also suggests that when you expose most folks to cosmetic surgery reality TV, they will experience a decrease with respect to self-esteem. And as you guys will see later on today, once we kind of talk about some theories of eating disorders, low self-esteem can be a cognitive change that can lead to disordered eating behaviors later on down the line. So ultimately, the culture today that seems to encourage eating behaviors specifically is more of a Western culture that encourages a thin ideal for women and a muscular ideal for men. More specifically, those working in entertainment or sports industries tend to be at an increased risk, as are those with more exposure to media, um, and those who live in more urban settings where geographically, physically, they're more likely to be surrounded by others who may be subscribing to these ideals. And so, taken together, again, this collectively just kind of proposes that while we do kind of think of eating disorders as being kind of this full, tried and true category, that perhaps they're more of a social thing. They are more of a culture bound syndrome, and it just so happens that we live within that particular culture. So there are three eating disorders that we're going to cover today, and the first step is anorexia nervosa, more commonly referred to simply as anorexia, or AN for short. There are three diagnostic criteria comprising of this diagnosis. The first of which is a restriction of energy intake leading to a significantly low body weight, which the DSM clarifies as being less than minimally normal. So there are really two pieces to this criterion. One, taking in less energy than one needs to maintain one's weight, and two, body weight eventually kind of following suit and dropping. We do typically use BMI to quantify what is less than minimally normal, but we'll get into that a little bit later on. The second criterion is an intense fear of gaining weight or persistent behavior that interferes with weight gain. So we've got some cognitive behavioral symptoms going on here. And what's significant is that we've already established that this person is losing weight. They're not taking in the energy they need to maintain a healthy weight. And so that's really kind of, it's important to keep that in mind because that sets the stage for this criterion B, because it doesn't really make sense for someone to fear gaining weight if they're in this predicament, or to continue to engage in behavior that is interfering with weight gain, which is why it's a symptom. And then finally, criterion C is a disturbance in the way in which body weight is experienced, or a lack of recognition of the seriousness of low weight. So you could, broadly speaking, classify this as really poor insight, to kind of tie back into some of what we talked about with the bipolar and obsessive compulsive related disorders, that this person is not fully seeing their situation for what it is, not recognizing the seriousness of what's going on. And there might even be a delusional component where this person is, again, objectively underweight, but views themselves as being heavier than they really are. We also have some specifiers with anorexia, which a lot of folks don't really realize. So with every case of anorexia, you do need to specify whether you're dealing with the restricting type, the binge eating purging type. Most folks are familiar with the restricting type and really kind of think of that as being exclusively what anorexia is. This would be when someone is engaged in 3 or more months of dieting, fasting, and or excessive exercise. So this person is limiting what they're taking in to their body, which is contributing to that low weight. But most people don't realize that there's also the binge eating and purging type as well, and that this isn't an exclusive behavioral pattern relating to bulimia, but it actually relates to anorexia as well. With this, we're dealing with 3 or more months of binge eating or purging in some way, which includes things like vomiting, laxative use, diuretics, and enemas. So binging or purging, one or the other. And with purging, the real difference between that and restricting is that we're not taking in that energy, we are taking in energy and then removing it, versus with restricting, energy just simply isn't coming in. Another point kind of regarding the binge eating is that the binge eating may be coupled with restriction as well, or the binges may be relatively small in nature. You'll see later on, once we get to bulimia and binge eating disorder, that we quantify what a binge is, versus the binge is kind of left up in the air in this case with no formal definition. And so it's very possible that binge eating might be more subjective. The person feels like they're eating a lot, but the binge might not meet criteria for the established binges that we'll talk about later on in the context of bulimia and binge eating disorder. It is also important to note that symptom crossover is common, so the subtypes should describe current symptoms. So a person might have had a history of both types of anorexia, but we want to make sure we're describing what's going on currently. Anorexia is very rare. It impacts less than 1% of people, about 0.5% of females, with the sex ratio being about 10-to-1. So does impact males, but very, very few. The average age of onset to the teenage years, typically between 15 and 19. So this is going to be one of the earlier onsets we talk about. And failure to make expected weight gain may be present in these cases instead of weight loss, because we're dealing with a growing population versus an adult population with an established weight. So we may not see weight loss as much as a failure to gain weight in a developmentally appropriate way. The ways in which we determine what is an unhealthfully low weight is we'll typically reference BMI. BMI is an imperfect construction, to be sure, but if we are using BMI, these are typically the ranges that we'll reference. For adults, we're looking for a BMI less than 17 is what the WHO and the CDC recommend. For kids and teens, you may not realize, but BMI works a little bit differently. It's not a static number. Instead, it is measured based on percentile. And so we'd be looking for a BMI that is in less than the 5th percentile, which if we relate this back to standard deviation, which we talked about a while ago, you'll recognize this is kind of falling several standard deviations away from the mean, 2 or more standard deviations away from the mean. So we're talking about weight that is significantly low and describing a small percentage of the population. The APA also counsels us to consider these numerical guidelines, but also factor in the build of the person, their weight history, as well as physiological changes. So these numerical guidelines aren't hard and fast rules, but should be taken into consideration collectively with the person's kind of full physiology and history. As I mentioned before, criterion C can border on obsessive or delusional thinking in terms of not really viewing one's body in the way that everybody else does. And because the eating disorders entail physical health as well as mental health, effective treatment should include collaboration with a nutritionist and a primary care provider versus exclusively treating mentally. And so for that reason, we're going to focus on the health complications that come with each of the eating disorders as well as we make our way through today's lecture. So some health complications that you'll see with anorexia. Blood tests may reveal a low white cell and platelet count. This is important to take note of because these indicate an increased risk of sickness. Basically, the immune system isn't functioning as it should, and so the person is more likely to get sick. As a mental health professional, these aren't tests that you'll be doing yourself, but these are things you would be these are things that the collaborating PCP would be doing. And so it's just important to kind of recognize things that we should be looking for. And you might even find yourself in a position as a mental health professional to advise or even suggest things that a physician should be looking at if they are not as well versed in the care of eating disorders. Anemia is something that a blood test may reveal as well. This is going to be a low iron level, and this is just indicating that the blood is not properly oxygenated, which is something that could contribute to just kind of low energy levels, fatigue in general. We may be dealing with dehydration as well as electrolyte imbalances, which include low chloride, potassium, and magnesium as well. Heart complications that are common for this group include a low heart rate as well as irregular heart rates. And other health findings that may be relevant include amenorrhea, which is when a female loses her ability to menstruate, or if we're dealing with a young enough female, we may see delayed menarche, which is the first menstruation. So again, if we're dealing with a young enough group, we might not see someone losing something like their ability to menstruate or weight, but we might see the absence of things like weight gain or menarche. We may also see low blood pressure as well as body temperature, osteoporosis or a thinning in terms of the density of bones. And then finally, we may also see lethargy, low energy, and major depression. Obsessive compulsive disorder is another really common comorbidity, particularly for anorexia. A perfectionistic, controlling personality is really common for this particular group. Another thing that I always like to point out about anorexia is that this is going to be the most fatal diagnosis within the DSM. About 5% of folks with anorexia die during each decade of follow-up, for two reasons. One of which, is a reason you may see with any diagnosis within the DSM, and that would be suicide. But what really kind of puts anorexia over the top is the starvation component. The fact that we're dealing with all of these health consequences, and so it's possible to die from the physical impact, the physical consequences of these behaviors. Bulimia nervosa, or bulimia, BN for short, is going to be our second eating disorder. With this, we're dealing primarily with binge eating episodes and inappropriate compensatory behaviors. And as I alluded to earlier, with the binge eating episodes in the context of bulimia and later on binge eating disorder, you'll see that we're defining these binges. So we've got objective binges here versus more of a subjective binge in the context of anorexia, which opens the door for those binges to potentially be smaller than these kind of well-defined binges that we'll be talking about here. So in order to diagnose a binge eating episode, a person needs to be consuming within a period of time an amount of food larger than what most individuals would consider eating in a similar amount of time in similar circumstances. They must also exhibit a lack of control over eating. So we take an amount of time, say an hour, and we take note of what the person is eating, and we determine somewhat subjectively, I suppose, whether or not most other people would consider eating that same amount of food in that same amount of time, same amount of circumstances. So we wouldn't be comparing an hour's worth of food during Thanksgiving to just kind of a regular dinner or lunchtime period. You'd want to make sure circumstances are consistent as well. And the person feels a lack of control. So there's a degree of wanting to stop, but feeling compelled to keep going. In addition, we must also be observing inappropriate compensatory behaviors, which is basically just any way to compensate for the binge. So this includes a lot of the behaviors that we listed off in reviewing anorexia: vomiting, laxative use, diuretics, fasting, excessive exercise, basically, again, just any way to compensate. Collectively, we're seeing a combination of A and B once a week for at least 3 months of time. In addition, the person's self-evaluation or how they feel about themselves is unduly influenced by body weight and shape. So how they feel, their self-image, their self-esteem, a lot of this really goes back to what they look like and how much they weigh versus, how intelligent they are or how proficient they are at various skills or activities, things that typically tend to make up self-esteem, self-image, self-evaluation. And then finally, of course, we want to rule out other causes, most prominently anorexia. I always like to share this as a case example of bulimia because it does a nice job of highlighting how bulimia can exist in places you might not expect it to exist. It also does a nice job of highlighting how certain behaviors can really set the stage for an eating disorder. So I came across this several years ago. I used to have a really great bulimia case that I liked, and it wasn't on YouTube anymore. And so I was trying to kind of find a substitute, and I stumbled across this. It's written by a guy who is writing into a YouTube channel. And he's kind of describing his current predicament. You can feel free to pause and read the whole thing if you'd like, but I'm just going to point out some of the big takeaways. So this guy cycles carbs, which is a practice in which one alternates between abstaining from carbs and consuming carbs. In this case, this guy has weekly refeed days where he's got a day where he is allowed to consume carbohydrates, but then the other 6 days of the week he does not. So his main issues with these days, they usually turn into binges of 5,000 to 6,000 calories or more. Fortunately, this guy easily diets down through the other 6 days, and the next week comes back to a pre-binge body fat percentage or less. He's tried several times switching to a steady, moderate carb diet instead of cycling, but describes himself as carbophobic, and so he often fails and comes back to the current carb cycling regime. And so he's writing into this guy to kind of get tips for what's, going on, how he can binge less on those days. And so let's compare this with what we just reviewed. So first up, we need at least one binge episode each week where we're eating a large amount of food and experiencing a lack of control. He has told us how many calories he's consuming, which is 2 to 3 times the number a person should be consuming in a day. So that's definitely a binge. And there's clearly a lack of control, and that he's writing this letter because he wishes he wasn't doing that. B, at least once a week, some type of compensation. So he is saying he diets down through the other 6 days. He restricts what he consumes in order to compensate for those binges coming back to that pre-binge body fat percentage or less, in his words. So this collectively is occurring once a week. We can assume that this has been happening for 3 months in this case, just for the sake of argument. If you take the time to kind of read through the rest of the letter, I think you could really make a case either way for whether or not this person's self-evaluation is based on what they look like. And my main aim in sharing this isn't really to debate whether or not this guy meets criterion D or not, but to show you why certain careers or certain behaviors are really high risk for eating disorders. It's because certain behaviors really set you up for the eating disorder, and that they check off all of the behavioral components of the eating disorder. And so at that point, the only thing that you really need to do in order to meet full criteria is you need to have a cognitive switch. So in this case, if this guy is not basing the way he feels about himself on his weight or what he looks like, all he needs is to make that small cognitive shift, and suddenly he's meeting criteria for bulimia. So it's highlighting how certain behaviors are really risky because you're just kind of right on the edge of meeting criteria, and you just need that one shift to really meet full criteria. It also kind of highlights how these disorders don't always necessarily look the way you think that they might look. Bulimia impacts about 1 to 1.5% of females with a similar sex ratio to anorexia of 10 to 1. These folks are typically normal to overweight with an adult BMI of 18.5 to 30. So that's kind of one difference that separates bulimia from some of the other eating disorders, is that it tends to be more of an invisible eating disorder because folks are not underweight, or in the case of binge eating disorder, significantly overweight. We're dealing with folks that look relatively normal. So for that reason, binge bulimia can sometimes kind of fly under the radar. Binges tend to be classified by the amount of food consumed versus the type, although people do typically tend to consume previously avoided foods, as in the case I showed you on the previous slide. Shame's really common. Triggers include poor mood, stress, restraint is a big part of it, as well as boredom and negative self-appraisal. And so for that reason, one of the techniques that I kind of take in terms of intervention is to address that restraint and kind of advise people more towards intuitive eating and kind of, moderate consumption of what it is that you want to eat, and not having fear foods or bad foods or foods that are completely off the table. Because when we restrain like that, that is really what sets the stage to overindulge later on. Dieting and, again, calorie restriction is also really common between binges. As far as the purges and compensatory behaviors go, vomiting is the most common of these behaviors, and it may even become the goal of binges. So people might hit a point where they've completely lost control of what they're eating, and so they're eating to the point where they naturally will become sick versus having to induce vomiting more directly. There are fewer tests available for bulimia nervosa than for anorexia, but some health complications that we may see include things like fluid and electrolyte imbalances, similar to what we would see from anorexia, potassium, magnesium, things like that. We may see enamel erosion, acid reflux, and esophageal damage that's associated with vomiting. We may also see menstrual irregularity or amenorrhea, depending upon the person's weight and behavior. They may not be consuming enough to maintain a regular menstrual cycle. Substance use is also a really common comorbidity, as are the depressive disorders. Bulimia tends to be, or seems to be, the most culture bound of the eating disorders. It's more modern in that people born after 1960 have an increased risk relative to those born before. There's also a social component in that we do see it diagnosed in higher rates in urban versus rural areas, where there is greater in-person media exposure. So there's media exposure, but then you're also physically surrounded by more people who may be unhealthfully subscribing to health trends, and all of that input can contribute to the development of this diagnosis. The most common eating disorder is one that you actually wouldn't think of. It's not one of the big three. It's not anorexia, bulimia, or binge eating disorder. It's something that was previously referred to as eating disorder not otherwise specified, or EDNOS. This was the DSM-4 term. Currently, it's referred to as other specified feeding or eating disorder, OSFED for short. That's the DSM-5 term. The terms are still used kind of interchangeably, and I admittedly use EDNOS more often than I use OSFED. It's just, I think, a colloquialism that, folks have a tough time switching over to. But these are basically the two terms that are used interchangeably and refer to this kind of weird catch-all category. It's a category that exists, or diagnosis that exists, within each category of the DSM. So there is an other specified depressive disorder, an other specified bipolar disorder, an other specified obsessive compulsive related disorder, and so on and so forth. Basically, these diagnoses exist within each category of the DSM in order to render diagnosis for a person who is clearly distressed and impaired, clearly presenting with symptoms within this general category, but is not meeting full criteria for any diagnosis within that category. And so we want to label them as having a clinically significant presentation, but again, they're just not meeting criteria for any of the other diagnoses because of the black and white categorical way in which diagnoses exist. One difference between OSFED or EDNOS and the catch-all diagnoses that exist in the other categories is that because there are really only 3 eating disorders, and binge eating was only added in 2013, so not too long ago. But because there are really only 3 and the criterion are relatively rigid and specific, a lot of people end up presenting with disordered eating who simply don't fit those criteria and end up falling into this category. In my opinion, this is a flaw of the categorical classification system, in that we have to continually create new labels to describe new people versus simply having more of a dimensional type of approach that encompasses everybody. But because we have categories, we end up having these catch-all categories. And so because of that, and the fact that we really only have 3 options for people, about 75% of people with eating disorders have OSFED/EDNOS versus having anorexia, bulimia, or binge eating disorder. And so it's this category that comprises a huge number of people, but it's a category that doesn't really communicate a ton of information because So many different presentations can fall into this category. I would suggest at this point pausing to watch this video about Taylor and Allie. These are two women with two very different presentations who both fall into the EDNOS OSFED category. They use the term EDNOS because of the age of the clip, but it really highlights how so much ends up falling into this category, and it ends up being a useful label, and then it communicates the clinical intensity of what's going on and the severity, but it's not really a super useful label outside of that, because if I see that on someone's file, it could literally mean, you know, anything that's not anorexia, bulimia, or binge eating disorder. It could mean Taylor, it could mean Allie, it could mean so much in between. And so binge eating disorder is our last eating disorder that we're going to talk about today. This one is the newest. It was added in the DSM-5. And basically with this one, we're dealing with binges. We've got the same definition that we reviewed earlier and going over bulimia. But in this case, there's no compensatory behavior, and the binges must be associated with 3 or more of these 5 symptoms: eating more quickly than usual, eating until uncomfortably full, eating large amounts of food when not hungry, eating alone due to embarrassment, or feeling disgusted, depressed, or guilty after eating. In addition, the person must be distressed by their binges, and the binges must occur at that familiar frequency of once a week for at least 3 months. We also want to make sure that we're ruling out alternative causes. And I would again recommend pausing to view this video of Robert with binge eating disorder, because he's got an interesting history. He's got kind of a trauma-based history, which again kind of highlights that, you know, even though PTSD has trauma in the name, not all trauma leads to PTSD. Some trauma leads to other diagnoses, in this case, binge eating disorder. He also does a nice job of likening binge eating disorder to food addiction, which is kind of what it is. It's someone who is compelled and pulled back to the same behavior again and again. It's causing distress. They can't stop, in the same way that someone is kind of pulled back to a substance-based addiction again and again, or even a behavioral type of addiction. This is going to be the most prevalent of the big 3, impacting about 1.5% of females and about 1% of males. It's going to be more common in normal to obese weight individuals. So in some cases they might be invisible, but in most cases it's visible, just in a different way than anorexia is visible. It is distinct from obesity, though. I do want to point that out. Only about 5 to 10% of obese individuals have binge eating disorder. So they're not mutually exclusive labels. This is but one of the paths that some people may take to arrive at an obese weight range. Folks with binge eating disorder typically have greater calorie consumption than obese individuals kind of independently who do not binge eat. Folks with binge eating disorder also tend to have more impairment, lower quality of life, more subjective distress, and greater comorbidity as well, compared to those who are just simply and independently obese. The health complications associated with this one really mirror those that complement obesity. So we're more likely to see cardiometabolic diagnoses here, things like heart diseases, diabetes, and whatnot. There are some racial, ethnic variations as well, in terms of things we might see or not see among different racial groups, or the way that even different racial groups are treated when they present with eating disorders. Caucasian females make up the vast majority of anorexia cases, like basically all anorexia cases. Restriction and purging are also the behaviors you're more likely to see from this particular group. Among Black or African American females, there's relatively little, some studies suggesting no anorexia. One particular study of more than 2,000 females conducted about 15 years ago indicated that there were no cases in this particular sample of anorexia among the Black female population. Binge eating is the most common behavior we'll see from this group. Some will kind of chalk this up to greater body confidence among this particular group, but critics of that explanation will point out that many of our eating disorders, in the theme of these being very culture bound in nature, have a very white definition. There is kind of a focus on a smaller body shape, a smaller body weight, that thin ideal I talked about earlier. And so possibly one of the reasons that we're seeing some of these things more from white populations is because they are white definitions of body dissatisfaction and white definitions of what disordered eating looks like. And that if we were to broaden this category to include not just body dissatisfaction as far as the size of one's body goes and behaviors that complement that, that if we were to also look at body dissatisfaction as far as things like skin color or hair texture go, we might start seeing body dissatisfaction more so from other groups and be able to intervene with those groups versus looking exclusively at more the things that white populations are more likely to report having a problem with. Another thing that I want to point out while kind of on this general topic has to do with the Asian population, specifically Asian females. Diagnosis of eating disorders may be overlooked among this group due to the petite stereotype. One such exemplar that kind of highlights that is on the far side of the screen. This one subject reporting that many of her friends weigh less than 100 pounds and keep losing weight, yet nobody calls that anorexia because Asian women are supposed to be tiny. Doctors are subject to these stereotypes too. At my last physical, I weighed 112 and the doctor was shocked as if I were fat. So that's kind of an added piece for that particular group as well, that we may be ignoring pathology because being small is expected and okay for that group when we might be overlooking something that's really dangerous. As far as precursors to disordered eating, there are several. Developmentally, mom being dissatisfied with the way that she looks can set the stage for eating disorders, as are unhealthy maternal and paternal BMIs in either direction. From a societal perspective, the internalization of the thin ideal, which we'll talk about a little bit more later on, can be a risk factor for eating disorders. More specific risk factors include social isolation and anxiety, including diagnosable levels of anxiety. Those can be specific precursors for anorexia. For bulimia, menarche at an early age, so getting one's first period at an early age can be a risk factor, in large part because the first menstruation kind of sets off puberty for females. And that comes with weight gain in addition to other changes. And so if this is happening to a young girl, a young woman, when her peers aren't going through the same thing, this can result in unwanted attention and also just starting to focus on one's body at a younger age, which can set the stage for bulimia. And then as far as binge eating goes, more specific precursors include early onset obesity, as well as early onset dieting and loss of control over eating. Other more specific causes, genetically, binge eating disorder seems to run in families and may be associated with the same genetic traits that drive other addictions. From a personality perspective, we'll see anxiety more so from folks with bulimia and anorexia, and more obsessive traits from those with anorexia. And environmentally, of course, we've got those thin and muscular ideals that are common in Western cultures. And the sociocultural theory explains more specifically what is kind of going on there. The sociocultural theory is comprised of 4 different stages that a person will pass through culminating in the development of disordered eating behaviors. So initially, people are exposed to thin ideals, and this happens at a really young age in our culture, especially now, I would say, with the influence of technology. Um, Barbie dolls, and like even from the male perspective, the body dimensions of like action figures like He-Man, Batman toys are really unrealistic as well. And so even early childhood toys and media oftentimes have these characters with these unrealistic bodies, these unrealistic ideals. And so step one in the development of disordered eating per the sociocultural theory is exposure simply to these ideals, whether thin or muscular. We're being exposed to like, this is what the ideal body should look like. Step number two is that ideal begins to be internalized, and internalization means that this ideal goes from being external to now internal, meaning that this person now believes that this ideal is personally important versus something that simply exists. So that first stage of exposure would be observing the ideal and like, okay, like that's neat. That's one way that a person can look. And internalization would be thinking like, okay, I now am viewing that person's body as important, something to idealize, something that I want to achieve. So there's this internalization process of this thing that was once external, now becoming internally and personally important to this individual and something to ascribe to. Step number three is observing a discrepancy between the actual and the body and the ideal body. So this body type is now important to me, and I'm realizing that I don't look that way. There's a gap between the ideal and what I actually look like. And then number four is to feel dissatisfied with one's body and to alter eating patterns in an effort to make one's body conform with the ideal. As I mentioned earlier, exposure begins early and it's very pervasive, particularly with technology the way that it is today. Societal normalization of ideals and social media can make the behaviors very, very difficult to quit. Social media algorithms are oftentimes echo chambers. And so if you are expressing attitudes, idealizing particular ideals or attitudes, encouraging disordered eating behaviors, you are more likely to be connected with groups and other people who have the same thoughts, the same opinions, creating again this kind of echo chamber. Formerly, we were kind of more worried about things like pro-ana websites, which are websites that people with anorexia can go to share what it is they do to lose weight and kind of bond with a community, which can be a particularly dangerous social interaction. But with social media platforms the way they are, really any of these platforms can serve the same purpose if a person kind of finds themselves in that corner of that particular platform. And so all of that just kind of encourages the behavior further and encourages the pursuit of these unrealistic ideals that are simply fake and not real. As far as treatment goes, as I mentioned before, the eating disorders are kind of funky in that there are mental and physical components to them. And so we need to kind of acknowledge that as far as treatment goes, and treatment is typically multidisciplinary. The normalization and stabilization of eating, a person's weight and their behaviors are the central treatment goals when addressing any of these behaviors. So particularly if weight is dangerous, especially if it's too low, but also if it's too high, that ends up being kind of the focus. Is we've got these physical health complications that are the direct consequence of a person's weight, what they're doing, the physiology of their bodies. And so we want to address those health complications first and foremost. That doesn't mean that the psychological pieces aren't important, but it just means from a health and potentially a life-saving perspective that these things are more important to address immediately. So with anorexia, typically what is done first is we'll increase caloric intake and weight gain. And typically this is done at an inpatient treatment unit. And weight is typically the first initial goal. This sometimes, if we're dealing with a minor, we might even be dealing with involuntary commitment of a minor to an inpatient treatment facility. I always like to, even though I obviously don't work in an inpatient treatment facility, I work at, my own outpatient practice. I like to make sure that clients and patients are aware of this when going to inpatient, that the goal is weight restoration first and foremost, and that depending on where a person's going, there might not really even be more of a therapeutic emphasis. And again, this isn't because therapy is not important, it's just because we're focused on putting out the biggest fire first. Because I have observed that sometimes people will go to these treatment facilities and just be really unsatisfied, unhappy with them. It's not what I expected, expecting more of a psychological piece. And again, there may be that, but there also may not be that, depending on the focus of the facility. So it can be helpful, even if you don't work at one of these facilities, to be able to properly prepare patients for the possibility of not getting a more holistic approach at these facilities. Overall, treatment, inpatient, outpatient, all of it is multidisciplinary. It should include nutrition counseling, possible medication monitoring if a person's on medication, and should definitely include therapy to address the underlying causes. CBT is helpful in addressing thinking patterns, and the recovery rate for eating disorders is about 35 to 75% and a 5-year follow-up. Family-based interventions can also be particularly helpful, especially for younger groups, especially, and when we're talking about younger groups, we're really talking about primarily young teens with anorexia. Because families are the ones who are able to give consent. Families are the ones who can take more of an empowering role in terms of what the family dynamics look like, whether there are dysfunctional patterns, if there are, working those out, working out what meal times look like, and things like that. And then much like with the last lecture, I'm not going to go into any demonstrations because we are online, so you can disregard that last chunk of this lecture and just kind of limit your understanding of treatment to what we covered on this slide. All right, that's all I got for you. Thanks for joining.